So if you can please turn on your camera, we are about to begin.
Is it okay right now?
Yes, sir. Absolutely visible. So, sir, it's sharp 4. With all your due permission, can we begin with the session for today?
Sure, ma'am. Go ahead.
Thank you so much, sir. Good evening, everyone. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our renowned speaker for today's session. He is none other than a very renowned nephrologist, Dr. D.K. Sinha, sir. Sir is senior consultant at the Department of Nephrology at Heritage Hospital, Varanasi, Uttar Pradesh. With the help of sir, we'll be taking a close look on today's topic, which is autosomal dominant polycystic kidney disease. So before moving on to today's session, let us have a brief look on what the topic says. Autosomal dominant polycystic kidney disease is a hereditary genetic disorder characterized by the formation of numerous kidney cysts. It often leads to progressive kidney damage, affecting their ability to function correctly. Although there is currently no cure for ADPKD, we'll be learning more about the treatment focused on managing symptoms and slowing down the progression of the disease with Sir's wonderful inputs upon the topic. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. So over to you.
Thank you, ma'am. Thank you for your very nice introduction and very nice introduction of topic also. As you very well said, that autosomal dominant polycystic kidney disease, in which the patient will have multiple cysts in the kidneys, which gradually hampers the function of the kidney and then will lead to different symptoms, including the renal failure, infection, stone, malignancy sometimes, will occupy the abdomen almost many times. That problem will be there. Not only this, patient may have problem at other organs also, like liver, brain, heart, and intestine. So this is not the only disease of the kidney. It's basically affects many organs. Patient. With this brief introduction, we move forward. And what is the autosomal dominant polycystic? Once we tell that this is autosomal dominant, I think we are having the mixed audience. So autosomal dominance means basically there is problem in the autosomal chromosome and there is dominance penetrance of the problem. So that's why it is called autosomal and that is called dominant. So even in the single chromosome is having the affected gene, this particular problem will lead to ADPKD. So this is autosomal dominant number one. Another is the incidence is quite high. 1 in every 400 to 1,000 people and can have this disease, and most common kidney disorder passed down through the family member. This is a basic genetic. Usually the patient who is having this disease either gets from his or her mother or father. And usual diagnosis is made between 30 to 50 years with the presence of cyst, mainly in the kidney. But other organs also, as I told you, may have the cyst. Possibly it happens due to the gene mutation or there is defect in the gene in only one parent. So there are basically two types of ADPKD. One is called ADPKD type 1 and another is ADPKD type 2. The incidence of PKD 1 type is very high if you're comparing with the type 2. Another way to see the overall incidence and prevalence, this is basically US data in which they have said that around 200,000 to 300,000 currently diagnosed patients in the USA, and around 6% of all patients who are on dialysis, they are basically having the ADP. And 10% those may be under 65 years of age. So incidence, prevalence, and survival rates and age of onset of ESRD are gradually increasing over the periods. This is fourth leading cause of ESRD. So we all know that the first one is the diabetic nephropathy, hypertension, glomerulonephritis. So this is the fourth leading cause of ESRD. So this is not a very uncommon cause of ESRD. Many patients of ADPKD can develop ESRD over the period. And we will discuss in detail who are the patients who are more prone to have this ESRD type of features. No race is favored, dominantly inherited as it is autosomal dominant. And patient may have the cyst in the kidney, liver, pancreas, spleen, brain. So not only it's basically a renal disorder, it's basically going to affect the many organs. And the problem starts in the utero. But mostly it is being diagnosed in the young age or adult age. But one thing is very sure, that disease has already started in the utero. Now coming to the molecular pathogenesis. As I told you, the incidence of PKD1 is around 85% versus PKD2, that's 10 to 15%. And PKD1 is more severe disease than PKD2. So coming to the number, the chromosomal number, the PKD1 usually occurs at the chromosome number 16. PKD2 happens at the number 4. This is the basically way of cystogenesis in the kidney or any other organs, because there is impaired synthesis of protein, and this protein weakening in the basement membrane and leading to formation of the cyst. So what happens, there is basically weakening, and then there is gradually pleural expansion of single epithelial cell, and there is bulging. Over the period, this bulge cut off from the main tubule and will usually act as the independent cyst. There is another hypothesis that is called two-hit model of ADPKD, in which two null PKD1 or PKD2 alleles are there, and there is problem in the one cell of the epithelium, which is gradual bulging, and there is gradually fluid accumulation. In future, usually detach itself from the main tubules and lead to the formation of cyst. And over the period, there is further fluid accumulation. There is enlargement of the size of the cyst. So now coming to the threshold model of the ADPKD, it's basically dependent on the critical cellular PC level. So basically what happens, as there is impairment in the synthesis of the protein, so gradually from the normal to lethal stage of the disease happens, and cystic disease increases over the time. And at the same time, there is decrease in the PC. So over the period, it happens in the patient, and then there is formation of the cyst. Now coming to the symptoms of ADPKD, that's very important, because these are the factors which brings the patient to the physician. So patient may have the variety of symptoms, including the headache, because I told you, patient may have some problem in the brain also. So mostly it happens in the form of aneurysm. At the same time, many ADPKD patients may have very severe hypertension, also can lead to pain in the back, pain in this side, blood in the urine. So hematuria may be one presentation. Increased stomach size because there is enlargement of the kidney. So patient usually feel bloating, feeling, and if one physician palpates the abdomen, can palpate the kidney bimanually. There is sense of fullness of the stomach. And these symptoms usually increase over the period, because as there is increase in the number of cysts and the size of the cyst, so patient then realize that something going abnormal in his or her, and then that brings the patient to the physician. So these are the 6 most common symptoms of ADPKD, including headache, blood pressure, some kidney issue, hematuria, and pain abdomen. Now coming to the complication of ADPKD. So ADPKD, as I discussed earlier also, will have the renal manifestation as well as the extrarenal manifestation. First, the renal manifestation. Hypertension is very common because most of the patients of AKD will have the hypertension. Nocturia, polyuria, hematuria, another problem. Palpable kidney and many times painful also. Sometimes patient may have the pain, severe pain. or infected cyst, stone, hematuria, or recurrent UTI may be the presentation from the renal side. Apart from that, if you come into the extrarenal manifestation, patient may have the intracranial aneurysm, vascular dissection of the main vessels like aorta. Valvular heart disease is very common. So prolapse valve is very common. Prolapse mitral valve is very common. Hepatic cyst is another very common presentation. Diverticulosis in intestine and abdominal wall hernia. These are the few very important extrarenal manifestations of ADPKD. Now coming in a little bit detail of the renal manifestation of ADPKD. There is usually progressive kidney failure due to the part of continued enlargement of the cyst. And this enlargement of the cyst gradually impaired the function of the kidney. So you will find there is gradual rise in the serum creatinine, meaning thereby there is fall in the function of the kidneys. Hypertension is very common. UTI is very common. Concentration defect is there, so that's the reason patient will have the polyuria. Hematuria is there, the patient is having stone or there is a rupture of the cyst. Nephrolithiasis is very common. Protein excretion is not that much most of the time. One may have, but the difficult problem is that if the patient is having autosomal dominant polycystic kidney disease, and if he or she develops some nephrotic syndrome-like a feature, and doing a biopsy really, really very difficult, and you cannot treat. Many times in these subset of patients, the open biopsy is being advised. So all complications relate directly to the extent of kidney cyst involvement, which can be assessed with the kidney volume, total kidney volume result. But apart from the renal, this ADPKD, there are a few diagnostic considerations one should keep in mind whenever making a diagnosis of ADPKD, like acquired renal cystic disease, autosomal recessive polycystic kidney disease, medullary cystic disease, or renal dysplasia, simple renal cyst, tuberculosis, sclerosis, and von Hippel-Lindau disease. I'm not going to discuss the detail of all these problems, but these are the few very important differential diagnoses one should keep in mind. So how to make a diagnosis of ADP? First and foremost thing is positive family history. So most of the patients, when whoever come to clinical practice, they are having very strong positive, but sometimes there may not. This is not the only criteria that somebody is having the family history will have the ADPKD. Even in the absence of family history, which may have the various reason, can have the ADPKD. And on investigation, what we usually get, that patient will have the multiple kidney cysts bilaterally in the renal ultrasound. So now based on the ultrasound, how one can classify the ADPKD? One is typical ADPKD. So in typical ADPKD, what we get usually is basically cyst distribution is bilateral and diffuse with relatively even contribution to total kidney. So these are few very important. If you are going to see the ultrasound of the patient, the cyst will be present in cortex and medulla, both kidneys. So this is not the specific site of the kidney which are being involved especially. So this is basically diffuse or total kidney volume distribution of cyst in the typical ADP. But in atypical ADPKD, what we can get, the patient may have unilateral cyst, asymmetric cyst, segmental, lopsided, bilateral presentation with acquired unilateral atrophy, bilateral presentation with bilateral kidney atrophy. So there may be various other presentation also, but the commonest one is the typical presentation in the patient. Now coming to the differential diagnosis, which I discussed already in detail, few others are also very important, like autosomal dominant polycystic liver disease is one condition in which the cyst is predominantly in the liver and very few in the kidney or may not find in the kidney. X-linked dominant orofaciodistal syndrome type 1 is also one differential diagnosis for this. Now coming to the investigation, being as a physician, it's our duty to do investigation. and to advise the patient how we can approach further. Most of the patients of ADPKD, you find that they are having the increased hematoma because many times there is over-excretion of the EPO from the tubules. Because you all know that this comes from the tubules. So mostly patients of ADPKD may not have anemia, even they are having the renal dysfunction. Now coming to the other important investigation like decrease in the urine concentrating ability, microalbuminuria, nephrotic renin proteinuria is very common, which I told you earlier also. If suspected patients of ADPKD having nephrotic renin proteinuria, one should have a different diagnosis also at the same time. Ultrasound is the procedure of choice because there is simple, easily available, cost effective also. Other imaging investigation may be CT scan and MRI because they are more specific and sensitive investigation. So in few patients, we may advise patients to go for CT and MRI. Genetic testing, sometimes this is being advised to the patient if you want to make a linkage, if you want to analyze the mutation. Now coming to the ultrasound specific. This is the most widely used imaging techniques to diagnose the ADPKD, and it can detect the cyst from 1 to 1.5 centimeter. Now, based on the number of the site, the age of the patient, there are two positive predictive value and the negative. I'm not going to detail because this is a very busy slide, but if you see the number of cysts, the age of the patient, based on that, you can make a diagnosis, positive predictive value and negative predictive value. But what is the chance that this patient is having AD? Another investigation is CT scan abdomen. This is very sensitive than the ultrasound. And this can detect cyst as a small 0.5 cm. So initially, when you are in doubt that whether this patient is having ADPKD or not, you can advise the patient to go for CT scan and then you can detect the cyst because CT can detect the cyst even at the smaller size. So this is very useful in the doubtful patients like in children or in the complicated patients. If the patient is having stone and suspecting tumor also. Another important imaging investigation is MRI. So this is the best imaging tool to monitor kidney size and diagnosis. Why we are discussing about the MRI? Because this is more sensitive than ultrasound and CT scan. And this is more helpful in distinguishing renal cell carcinoma from this. So MRI is more sensitive test, imaging test. So finding of fewer than 5 renal cysts by MRI is sufficient for the disease exclusion. If somebody is having less than 5 cysts, then we can exclude the diagnosis of MRI. This ADP. Now coming to the prognostic calculation, because I told you earlier also that not all patients will have the same prognostic rate, that progression of the disease. So there are two very important ways to make a prognosis of the patient. One is Mayo classification and another is PRO-PKD calculation. So another very busy slide, but based on the Mayo class clinical ADPKD classification, what we are supposed to do that we can make a cut and we can see the total kidney volume, and at the same time we can put the different values in the calculator. Based on that, we decide what is going to be the class of that particular patient. So there are 4 main class: 1A, 1B, 1C, 1D, and 1E. So patients who are having higher volume of total kidney volume, they are more prone to develop the complication in the future. So based on that, we can make a diagnosis. Another classification is PRO-PKD, prognostic scoring, in which there is point system. So few important parameters that are being taken for this one is male, hypertension, neurological event, or type 1 or type 2 type of PKD, non-truncating or means mutation type of mutation or truncating. The score less than 3 exclude the progression of ESRD before the age of 60. So lesser the value of points, chance to develop the ESRD before 60 is the less. The patient who are having the higher score. So few important points to keep in mind. Male carries 1 point. So male are more prone to develop disease. Hypertension is another very important, and urological event is also very important. So these three makes the point of 5 or so. So 2 plus 2 plus 1. So male hypertensive patients and patient who is having urological event, they are more prone to develop ESRD in the early stage. Now coming to the treatment, which is also very important because we know that there is no definitive therapy, but at least we have to offer something to retard the progression, the disease in the patient. So what are the important part being as a physician we can do for all? One is control of blood pressure. Another is control abnormality related to renal failure, treatment of urinary tract infection, treatment of hematuria, and reduce abdominal pain produced by the enlarged. So this is the approach. If the patient is having renal cyst, first confirm the diagnosis of ADPKD. If it is typical, then you can make Mayo classification 1C, 1D, or 1E, or Mayo 1 or B. So Mayo 1 or B are having the better prognostic marker. C, D, and E, they are having the poor prognosis because it's having a rapidly progressive ADP. eGFR is more than 25, less age 18 to 55, then you can start use of tolvaptan, which I'm going to discuss in little detail. Other factors we have to keep in mind, we have to make a target of blood pressure, we have to restrict the sodium intake, we have to keep the hydration adequate, maintain the normal BMI, cholesterol should be well controlled, and moderate protein and phosphate restrictions should be given. Maintenance of serum bicarb more than 22 is also being recommended. Now coming to the blood pressure control. So blood pressure is one factor which really play a very important role. And if somebody is having very strong family history and very strong clinical indicators for ADPKD, the target is various. So as a standard, we can keep the blood pressure less than 130 or 80 in the early ADPKD patient if the patient's age is less than 50 and age is more than 60 also. So for younger age, we have to keep very strict blood pressure control. For older age, we can be a little liberal. And if you're going to talk in the terms of the drug of choice, definitely ACE inhibitor or ARB, they are the drug. Fluid intake should be normal usually, but not much water intake should be. Because vasopressin receptor signaling is central to disease progression. Due to its impact on increasing cyclic AMP level, this is a key driver for cyst. So daily intake of should be that patients should have an adequate sufficient urine output. Sodium chloride consumption should be decreased. So ideally, there should be limitation of the salt intake, and salt intake should be around 3 to 4 grams. Healthy diet should be definitely advised for each and every patient. Obesity definitely should be avoided by the patient because higher BMI, more chance to have higher size of the total kidney volume, and patient will have the more rapid progression. Caffeine, because it inhibits the phosphodiesterase, so and increase the cyclic AMP in the epithelium, and then we all know that the cyclic AMP is the key factor for increasing the size of it. So it also increases the BP, but on the total kidney volume and EGFR is negligible. Patient can consume coffee, but excessive amounts should be avoided. Role of smoking is always very important. Any CKD patient, so it should be must stop, and there should be no intake of any form of tobacco and smoke. So as I told you, the cyclic AMP plays a central role in the ADPKD. And because cyst epithelium, basically, there is increased synthesis of cyclic AMP. And this ATP is being converted to cyclic AMP, which calcium inhibits adenyl cyclase, and PD also involved in reducing cellular cyclic AMP. So that's the reason, based on this criteria, this hypothesis, there is rationale of vasopressin 2 receptors antagonist is there, because this controls the cyclic AMP generation. So that's the reason the V2 receptor signaling driven by the vasopressin. What we use in the clinical practice for the ADPKD is use of tolvaptan, which is basically vasopressin 2 receptor antagonist. This hypothesis comes from various studies, but one of the important studies which I would like to quote here is Tempo 3:4 trial, in which patients who were taken for this study were having the size of kidney more than 750 ml, age 15 to 50, GFR was good, 60 to 60 ml per minute or more. The patient taken were in the 2:1 from tolvaptan and placebo, and dose of tolvaptan was 14, 45, and 15 milligram to 90 to 30 milligram. What was the conclusion of this study? I'm not going to detail. That tolvaptan, when it was compared with the placebo, there was slowed the increase in the total kidney volume and decline in kidney function over the 3 years. But it was also associated with the higher discontinuation rate. Reason, it's adverse. So what happens once the patient is taking tolvaptan? That there is low growth of the cyst. That's why better preservation of the GFR. So there are various studies, 3, 4, reprise, and all that, but I'm not going to in detail. Other drugs which are also used is somatostatin analogs with the variable outcomes. These are the few metabolic targets for the future therapy of ADPKD. People are working on this. There are a few other drugs which are under trial. They are, they say, valitinib, which is basically a multi-tyrosine kinase inhibitor. Other drugs are glucosyl ceramide synthetase, just for the academic purpose, are there. UTI is very common, and that's also increased the progression of the disease. So gram-negative substance is very important. So once the patient develop UTI, one should treat the patients very aggressively, because very few antibiotics penetrate the cyst properly. So mostly quinolones and sulfa drugs, and clindamycin and chlorpheniramine. These are the drugs which are able to penetrate in the cyst. That's why once the patient develops the cystic infection, one should be very cautious in using UTI. Flank pain is also very common presentation. So if somebody develops flank pain, either due to the stone or enlargement of the kidney, because there is a stretching of the fascia outside, and I'll just think tricyclic antidepressant, sphenic nerve blockade, or laparoscopic surgical cyst penetration, renal denervation. These are the few things. Nephrectomy and arterial embolization are done very rarely in very severe cases. Renal transplant is another final way to treat the patients of ADPKD who develops ESRD. It's almost same, but sometimes in some of the patients, because it covers the whole of the abdomen, many times prior to doing the transplant, patients are under are advised to go for this nephrectomy, native kidney nephrectomy, and then followed by renal transplant. Now coming to the unilateral or bilateral nephrectomy, somebody is having a recurrent infection, marked limitation of day-to-day activities, suspected malignancy, extension of native polycystic kidney into the potential pelvic surgical sites, uncontrolled bleeding, and development of ventral hernia due to the massive renomegaly. These are the few causes in which nephrectomy is being advised. I think to summarize, we all know that this is not an uncommon cause of ESRD, and many patients can develop ESRD of the period, but this is not the renal limited disease. Other organs can be involved, including the brain, heart, liver, intestine, valve also. And few patients who are male patients, hypertensive patients, patients of type 1 PKD, patients who are having urological complications. These are the patients who are very prone to have a rapid progression of the disease. So we have to select those patients. We have to do a very aggressive control of blood pressure, avoidance of excessive salt, avoidance of nephrotoxic drug. Then if the patient's cyst is being enlarged, tolvaptan is one drug which can be tried. People are using it in some of the patients with very encouraging result. Not the ESRD can be prevented, but of course the duration to have the ESRD can be prolonged with the use of V2 receptor antagonist. So with these words in this presentation, I end here and request any question query from the audience. Thanks a lot.
Thank you so much, sir, for the wonderful input that you have pondered upon today, which you are wonderful inputs upon the topic. We have a few questions I would like to put across from you.
Ma'am, your voice is not very clear.
Just give me a minute, sir. Sir, I have put down the question in the chat box as there is some disturbance with the voice connectivity. If you can please read from there.
Can you repeat, ma'am?
I have written down the question in the chat box. Can you please read from there as there is some problem with the voice connectivity?
Okay. Which is the preferred investigation for screening at risk family members of the person with ADP? That's very good question. I think clinically very relevant question also. So ultrasonography is very useful investigation. But if somebody wants to be very sure, then one can go for a genetic testing also. But ultrasonography is mostly very, very useful and very sensitive test. And as I explained earlier also, use of CT scan and MRI can differentiate very well patient who is having ADPKD or non-ADPKD. Number of cysts, as I told, the MRI, if it is less than 5 or so, you can exclude the diagnosis ADPKD. So ultrasound is number one. And genetic testing, in case if you want to very much sure, and other imaging tests like CT scan of abdomen and CT scan of MRI of the kidney, these are the two other very useful imaging tests. I think the first line of drugs should be ACE inhibitor and ARB. I think tried to explain in my presentation also, because ultimately the progression of disease basically is enlargement of the cyst, and there is changes happening in the interstitium of it. So here definitely ACE inhibitor or ARB plays very important role. Few things you have to keep in your mind, that hyperuricemia is also part of ADPKD. Most of the patients you will get the hyperuricemia. You have to treat the hyperuricemia. At the same time, you have to keep close watch on the uric acid value. And some of the ARB which are supposed to be behave as a hypouricemic drugs may be the preferred, but other also you can use, like, because ACE inhibitor and most of ARB, they basically increase the uric acid. So you have to be a little bit vigilant. Now, next question is approximately what percentage of patients with the disease progress to industry? I think this question is really very important. This is a progressive disorder. So all the studies which are done, whether patient is going to develop ESRD before 60 or after 60. This is a progressive disorder. But at the same time, patient is having complication at the other organs, like somebody is having a cerebral aneurysm and bleed, can lead to anything, subarachnoid hemorrhage, valvular problem, diverticulosis and leading to infection. There are other complications also. So this is basically a progressive disorder. So many things happens in the patients, but it is going to progress. Most of the patients. Female are little bit immune. Well-controlled hypertension and non-hypertensive patients are little bit immune. Patients who are not having neurological problem, that little bit immune, because their chance to develop ESRD is less before 60. It is always there after. So risk factor I told you, one is gender, that is male. Then another is presence of hypertension, then neurological complications, type 1 PKD, and whether it is truncation or deletion, that also plays very important role. Then smoking is another, obesity is another. These are the few factors which can increase the progression of AD.
Thank you so much, sir. Thank you for answering all the questions. That was the last question for today's session. And at the outset, I would like to thank all the viewers for taking out their time and for their ardent participation that they have shown by putting up such interesting questions to us. So thank you to all of them. And I would also like to thank you, sir, for taking out your valuable time and for being here at our platform and solving the queries of our viewers who were here with us. We hope that the knowledge shared by you will definitely help them in their daily clinical practices. So thank you so much, sir, for that.
Thank you. Have a
So
great
with all your last comments, sir, we can conclude the session here for today.
Yes, I think ADPKD is one of the very important cause of renal failure in the clinical practice. Around 6 to 8% of patients on dialysis are basically ADPKD patients. So it's not an uncommon disease. Can lead to many complications, the renal as well as the extrarenal complications. So this is basically, if you are going to see the patients without any family history, one should be little suspicious if somebody is presenting abnormal presentation like abdominal pain, hematuria, pain abdomen, enlarged kidneys. These are the few presentation in the general practice. Somebody can see and one can make a diagnosis, and cause strict control of blood pressure is the only thing which we can offer to patients. Other is the use of V2 receptor antagonist. I think that in near future we may have the injectable V2 receptor also, but right now this is the one drug which is being recommended to be used in the ADPKD patients. So these are the two drugs which are available with us right now. Other drugs are in the research stage, so we have to wait for that. Lifestyle modification, weight reduction, cessation of smoking, decrease in the salt intake, very good blood pressure control. These are the very important factors we have to keep in our mind and should advise to each and every patient for having ADPKD, even any cause of CKD. For the ADPKD, it's very important. Thank you.
Thank you so much, sir. With this wonderful note, we are concluding the session here for today. Until next time, we hope to see you soon at our platform again with an interesting topic and with all your wonderful inputs upon
Bye.
that.
Bye, everyone. Bye.